Good afternoon and welcome to another webinar Wednesday. Today we are joined by Andy Ulvenes, Chief Operating Officer at Renovo Solutions. So thank you to today's sponsor, Renovo Solutions, the trusted HTM partner for comprehensive biomedical and imaging equipment services. Their award-winning CMMS, Renovo Live, provides open book access to all cost and service event information. Renovo also leads the way in medical device cybersecurity and capital equipment planning tools. So for more information, please visit renovo1.com. Okay, today's webinar, as usual, is eligible for 1 CE credit from the ACI, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Also, just a quick reminder to please join us for our HTM Mixer being held at the Doubletree Resort Hilton Hotel in Scottsdale, Arizona. So that's next month, that's May the 7th and 8th. Now, mixers are a slightly modified, smaller, shorter duration and less crowded event that still provides valuable continuing education, networking, and of course, vendor engagement opportunities. For more information and registration details, please visit htmmixer.com. Okay, let's kick off today's webinar by giving away a Swissforce Meister multi-tool. So using the questions feature on your dashboard, let me know the answer to the following trivia question. April is National Pecan Month. Which state is the largest producer of pecans? I'll reveal the answer and our winner at the end of the webinar. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on your dashboard. Now, as I mentioned earlier, our presenter today is Andy Ulvenes. So, Andy, you may begin whenever you're ready.
Thank you, Linda. Appreciate it, and everybody loves a mixer, so that sounds like a good time in Scottsdale. Hey, thanks. Thank you, Linda, and thank you all of you out there in the webinar today. Appreciate you taking some time to spend it with us. As Linda said, I'm the Chief Operating Officer for Renovo Solutions, but a little bit more background. I've been playing in the HTM sandbox for 2.5+ decades. It's a great industry, a great place to be. Leap out of bed every morning thinking about all the opportunities for us to conquer in the healthcare world, and go to bed at night sleeping soundly knowing that we deliver great quality, high quality, great, safe patient care. So it's an exciting time. I spent a little bit of my career early days in working with OEM. Then I transitioned to an in-house organization for a decade and stepped out of there, did a little managed services and cybersecurity over HTM, and have been over here at Renovo Solutions for the last 3.5 years. So excited to talk to you. And with all that kind of context and background, as we thought about the topic today, as healthcare continues to kind of changing landscape, really think about HTM and economics and how to think about this in some different ways as we continue to move through a rapidly evolving healthcare landscape. So the way I organize today is into a couple of different buckets, 3 of them specifically. The first one here is just kind of thinking about from vendor management, how do we really get to all of the critical assets we cover? How do we move to asset intelligence? Then I'll get into a section about a little bit more of the economics and kind of the service delivery models of medical equipment service. And we'll wrap with service contracts as a strategic supply chain function. And I'll kind of wrap this all together at the end, and then we'll get into some Q&A, as Linda said, trying to leave a little bit of time for us there. So as we go through the presentation today, if you have questions, just fire those in, and I look forward to answering those when we get done. So let me kind of set the landscape here, and we probably, for those of us who've been around, we always hear there's pressure in healthcare, but the pressure is real and probably more than I've seen it in my time. So just kind of a reality check, the U.S. Healthcare system operating margins started 2026 at a negative 0.6% margin. It's the largest month-over-month decline in more than over a year as it relates to healthcare systems. So the operating margin, and many of us have heard, no margin, no mission. The pressures on that continue to be real. Changing legislation impacts that. And so hospitals are really looking at how do they offset some of that pressure. The other thing that's interesting to note is non-labor expenses. Historically, healthcare has been really labor cost driven. And non-labor category includes purchase services, supplies, drugs. This is actually growing faster than labor costs for the first time I ever remember, but certainly in recent memory and recent history. Purchase services alone grew 9% year over year, and yet for most healthcare systems, HTM still operates in a fragmented tactical kind of function, disconnected from the enterprise financial strategy. So today, I want to talk about, why that has to change and how leading healthcare systems are making that change. That's kind of the why the conversation, why this conversation, why now. So this isn't a conversation about what some of us have maybe been in about how do I fix the CT scanner and how do I get it up faster. This is going to be about how to think about HTM the way your CFO, your COO, CEO, or maybe a supply chain VP, and certainly your board at a healthcare system is thinking about enterprise cost management. We're going to cover three kind of interconnected shifts from the vendor management to asset intelligence. We're going to get in from kind of default contracts to how do we deliver an optimized service model or service economics. And then we'll get into kind of how do we get from passive contract administration to really active contract governance today. So diving into kind of the asset intelligence, why CMMS is no longer enough. So most HTM departments run on CMMS, and CMMS, which is a computerized maintenance management system, is essential for managing work orders, PM schedules, and all the regulatory compliance that our programs deliver. But here's the problem. CMMS tells you what happened. It is a look back into the past, and it doesn't tell you what to do next. It doesn't connect a ventilator's maintenance cost to its utilization rate, its remaining useful life, or the financial performance of the service line that it is supporting. We need to move from a system of record to a system of insight as a HTM industry. Most organizations have this data in totality, but it's scattered across the CMMS, the ERP, the EMR, the electronic medical record or electronic health record, and maybe several vendor portals where that data is residing. And it is very difficult to consolidate. It's not really a technology gap because the data is there. It's really about how do we drive integration and how do we drive governance. How do we kind of transform that into asset intelligence? Means combining 4 data streams most organizations keep in separate silos. Maintenance history from your CMMS, financial data from your ERP, utilization data from your EMR or your EHR, or maybe there are scheduling systems, and contract information from vendor performance data. When you bring all these together, you can answer questions that no single system can answer on its own. Questions like, for example, what is the total cost of ownership of our MRI fleet versus what we're getting in clinical throughput for that same MRI fleet? Or other questions like, which service contracts are we paying for coverage on equipment that has been decommissioned? These kind of 4 pillars, as I think about them, the data model, the maintenance, the financial, utilization, and contractual are really what will allow us to move from historically how we've managed the contracts or the vendors to being able to allow ourselves to have asset intelligence and really talk in a different way to our health systems. The next slide here, just kind of how do we do that? How do we link that performance? So here's a question I think that we should take back to our teams. Can your HTM department tell your CFO what is the cost per scan on your CT fleet? Could they tell your chief medical officer how much clinical downtime was caused by equipment failures last quarter and what that cost the organization in terms of lost revenue or maybe patient throughput? These are the connections and I think the discussions that turn HTM from a cost center into a more strategic partner. In my experiences, most organizations don't have this kind of information or have thought about pulling this information together. As a result, we often see massive confusion and a lack of understanding, which resorts back to what I consider more simple operational KPIs. This kind of variation really only persists when you don't have visibility and transparency. So to put a real fine point on it, traditional KPIs, PM completion rate, mean time to failure, turnaround time, they're all necessary, but they're not sufficient for us moving forward. Value KPIs, things like cost per procedure, revenue impact of downtime, total cost of ownership versus replacement cost are where we really need to go as an industry. And benchmarking like this requires standardized data, which most organizations have a hard time getting to. So when we talk about KPIs and how do you take this to the next level, if you want HTM to have a seat at the executive table, then I think you need to speak the language of the executive table. And that means, in some examples here, KPIs like total equipment service spend as a percentage of net patient revenue, probably ways that we haven't talked about or thought about reporting our kind of performance, but cost avoidance from optimized service strategies that we'll talk about in a little bit. Equipment availability rates tied really to specific revenue generating service lines, and capital versus maintenance spend ratios that would inform replacement planning. These are metrics that your CFO, your COO, and your board can really act on. And they are while they are difficult to get, if you don't have the data governance, if you don't have standardized processes and procedures across your health system, they're nearly impossible. And you also need to include your vendors and your contracts as part of that data collection strategy. This would get us to show up in a way that can speak to asset intelligence and value, right, to the systems that we support. So the new kind of economics and medical equipment service, the ways I think about this, for years, the default has historically been kind of relatively simple. Buy the equipment and sign the OEM service contract and kind of move on as someone in the health system. But that model made sense when hospitals had limited technical capability and when OEMs were the only option. But three things have changed that I wanted to share with you. First, the independent service organizations like Renovo, that market has matured significantly. Third-party providers now offer multi-vendor expertise at rates that could run 15 to 30% below OEM pricing for comparable services. Second, the biomed workforce is more capable and credentialed than ever before. Lots of tools and technologies have enabled our teams to become more skilled, more capable, and more credentialed across the HTM industry, even while we face acute staffing shortages. And third, the regulatory and right to repair landscape is shifting in favor of competition. I think Wisconsin was the last one that just signed into law their right to repair for all 50 states. So it is moving forward in the positive direction to allow competition and allow options. So the question is no longer, do we use the OEM or not? I think it's about really what is the right service model for each asset class. So let me take a second and dive into a little bit more of what that means. So there are lots of options, historically, OEM, ISO, in-house, and historically that's probably been looked at as a binary one or the other option. And I believe it's not necessarily binary, it's a spectrum. It's not versus, it's how do we work these together. And so to be really crystal clear, this is not really me telling you what the preferred model is, or there's not one size fits all, and it's certainly not an anti-OEM message. I think OEMs and service contracts deliver real value in specific situations, specifically around complex imaging systems, software-dependent platforms, certainly equipment under warranty, and situations where regulatory compliance requires manufacturers' support and involvement. All great reasons why to use the OEM and the value that they bring to our healthcare system. The problem isn't the OEM service, it's really the default moving into an OEM contract. When hospitals sign OEM contracts without benchmarking, without evaluating alternatives, and without thinking through the scope, it typically often overpay or underutilize the services in which they're paying for. And when OEMs bundle services, parts, and software access into opaque contracts, hospitals lose visibility into what they're actually buying. We hear this quite a bit in the customers that we work with and some of the frustration and pain points. In addition, hospitals may be quick to dismiss ISO services for historical fear of quality or service. And in reality, as we stated, they're really multi-vendor experts, and they are trained to service every manufacturer. As mentioned earlier, the landscape has changed, and service and quality with ISOs is typically equal to or better than an OEM. The highest, just share with you kind of a view of the highest performing programs. So highest performing HTM programs we see are really running what I call a portfolio approach to the service delivery. They're keeping OEM contracts on the most complex imaging equipment, using qualified independent service organizations for mid-tier multi-vendor where expertise matters. And it's not just about the cost, it's about matching the right service model to the right risk profile of your assets and your equipment. A portfolio and a mix need to be continuously reviewed as capabilities improve, complexity reduces or increases, and technology advances. A couple of best practices I thought that would be great to share on as it comes to HTM programs in this space in the portfolio is first, annual reviews of your risk profile and where you are balancing complexity, risk, and strategic value to your organization. Second, make sure that you're matching your service model or service delivery to the asset segment that you have. And lastly, push for transparency by trying to avoid bundled pricing, auto renewals, proprietary lock-ins on coverage for lower risk or longer life devices or assets. So kind of how do we manage risk? The uptime, staffing shortages, there's a lot of risk that is happening in the HTM space, and every HTM leader I talk to is dealing with the same tension: more equipment, more complexity, and fewer qualified technicians. The answer isn't just simply hire more people. The talent isn't there. It's about deploying your internal team on the work that matters most and strategically outsourcing the rest. Predictive maintenance powered by AI and IoT monitoring is starting to change the equation. We are seeing that AI-driven monitoring, for example, can reduce unplanned downtime by up to 40% on certain imaging platforms. So it can be a force multiplier in some cases. But you don't need a full AI rollout to start. While that's the sexy talk now of AI, you don't need it to start. Even basic utilization and failure trend analysis can really help you prioritize where your team's time goes and should go. A couple of things I'd like to call out here is that, the biomed workforce shortage is structural. It's really not cyclical. So I know a lot of times we think it might go away, but it is a structural thing that we have to lean into, and larger training programs and pipeline development has to be a key strategy with financial support and backing in your annual plans to build this and develop this area. The second thing, predictive maintenance and remote monitoring. I kind of mentioned on it, AI is like the hot topic and everybody's curious about what AI can do. I think there's an incredible amount of potential. There are lots of use cases, but really the talk should be focused on how can you really implement it? Where do you get the most return on your investment? and how is it supporting your organization so that the efforts and the investments made in this space are actually delivering the results financially and operationally, but it's also a sustainable strategy. The kind of transitioning to the next piece here is the service contracts as a strategic supply chain function. So why service contracts are now these big cost levers? I talked about purchase services and it's outpacing labor growth. So this area is now becoming kind of, think about it, in sharp focus. And really what we should do is let's talk about the dollars. So medical equipment service contracts typically represent more than half of the HTM department annual service and maintenance budget. When you roll that up into the bigger category, as I mentioned, you're looking at one of the fastest growing line items on hospital P&Ls. Purchase services grew nearly 10% year over year in recent quarters. And here's what makes service contracts unique as a cost lever for health systems. Unlike drug costs or supply costs, these service contracts for HTM are highly variable and they're highly negotiable. The same equipment with the same service scope may have wildly different pricing from one hospital to the next. We actually see this consistently within organizations and certainly across the industry with the crazy and wild variation in service pricing. It's not a supply chain issue, just to be really clear. It's just really an information gap. It's not uncommon to find hundreds of GL strings in a health system where costs land for this space. At the system level, a facility level, or a department level are all logical and rational areas on where these costs sit and maybe should sit, because who's accountable is overseeing them. And that makes organizing the data centrally a huge effort, and most systems lack the capacity to do it with all the competing priorities. Because this is one of the largest growing categories, this is an area that just simply can't be ignored, or we can't kind of default back to the effort is really hard in order to get this information. So capturing it and centralizing it is an urgent need and to get a real understanding of your spend so that you can communicate risks as well as opportunities in your health system. So where do we see some common sources of contract leakage and redundancy? When we look at service contract portfolios across our customers, we consistently kind of find some similar patterns. While there are many here up on the page, I want to just cover a few quick ones. First, coverage on decommissioned or retired equipment. You'd be surprised how often hospitals are paying for service on devices that are no longer in inventory. When we engage clients, typically for the first time, we typically find that inventory accuracy is 30 to 50% right, meaning there's a bunch of equipment that they don't know they have, and there's a bunch of equipment that they have that they're paying for that they don't have in their inventory. Second, overlapping coverages, where an OEM contract might cover PM, but the in-house team is also doing PM on the same devices, and or where there is warranty coverage, but that device is either being sent out or covered by an in-house group. Another area is bundled contracts, where you're paying for coverages, tiers that you don't necessarily need. Full service coverage on a device that maybe only needs ad hoc parts and labor. And lastly, the lack of the utilization data to match coverage levels to actual use. Every one of these is a recoverable spend and an opportunity for organizations to really look and dig in and understand how to optimize their service contract spend. So as you look at that, how do you think about this? How do you benchmark? Like, am I at the highest level? Am I spending more than I shouldn't? Should I dig into this stuff? And so benchmarking, which is pretty common for service agreements against peer data health systems. But here's a data point that I think every chief financial officer would grab their attention. It's very common to see different prices being paid for service contracts on the same model of medical equipment. In one example, we have seen 100 different price points from the same supplier. And that's not just a little variation, that is an order of magnitude as it relates to the variation that we see across contracting and across pricing. As we said, they're negotiable and they're variable. The hospitals paying the least aren't necessarily just lucky, so we shouldn't land on that either. They typically have better data, better governance, and better discipline when it comes to managing those contracts. Benchmarking, when done, is typically done at a higher level and kept simple for us to understand and a quick exercise. There's no industry standard nomenclature for how we classify assets, how we name them. So it's very hard to normalize data sets. Benchmarking isn't just about knowing whether your pricing is good. It's about understanding what scope, what response times, and what uptime guarantees, as well as what parts are included compared to your peers, and then comparing what they pay. So pricing alone without context is really just a number. So be careful of that. And most organizations have so many competing priorities that ones who have had the ones that have a level of governance and discipline are very rare. And that makes this a big compounding problem for our healthcare systems. Remember, an effective benchmarking really requires apples to apples comparison. And for those running the benchmarking, clarifying the details so you get what you need. And getting into kind of the beyond just the data and the details. So data and benchmarks are necessary, but they're not sufficient. You also need governance, meaning a defined process for how service contracts are renewed and approved, how they're negotiated, and how they're monitored. The best program I've seen really have what I'll say 4 elements to them. Centralized visibility into all active service contracts across the enterprise, a standard review process triggered well before renewal dates, so there's not a rush and urgency or shortcuts on decisions. Cross-functional involvement from HTM, supply chain, finance, clinical operations input as well. And then the 4th, ongoing performance monitoring against SLAs, KPIs, and commitments. So this isn't about creating bureaucracy or trying to make more in the way so it goes slower. It's really about creating discipline. You can bring these things together and do it in a quick nature. And it's about making sure that HTM contract decisions are made with the same rigor that our supply chain leaders apply to medical surge purchasing, pharmaceutical purchasing, and other strategic initiatives for their organization. 2 things to call out on this slide for me would just be the central contract repository. So I don't think it's important on who has it. It's more important about where is the single source of truth that is defined and established for the organization so that those HTM service agreements are in there, and also who is accountable to make sure that those are maintained, to make sure that they're updated regularly as that information and assets change on a regular basis in our organizations. And the second thing I was going to call out is just performance monitoring. So, this gets into just good discipline of quarterly service level agreement reviews, building out vendor scorecarding, tracking cost per device at the asset level, and then also kind of trending that over time. How is that trending quarter to quarter, year over year, and what, to deliver you what actions you can take as an organization. So I'm going to kind of segue here and kind of walk into kind of some of the key summaries and key takeaways. Those are the 3 areas that we covered, the asset intelligence, the economics, and then the contract as a strategic function. But let me kind of walk us through into some kind of key takeaways here for us. So, I want to make sure that it's clear that this isn't 3 different initiatives and how do you start to tackle those. We've covered a lot of ground, but it's really how do you drive one full, complete, integrated strategy. Asset intelligence will give you the data foundation that we need to start showing up in a different and better way. The optimized service economics give you different delivery models and contract and different delivery models that will help you manage your risks and your costs for your assets. And then the contract governance piece really gives you the overall kind of puts in place and cements the financial discipline to give you a long-term sustainable HTM program. So together, these are things that I think will help transform HTM departments from a reactive kind of vendor managed function into a proactive enterprise aligned capability. And this matters not just for cost management, but I think also as a strategic function and a strategic value add for our healthcare systems. As I mentioned, our executives are constantly looking for ways that their organizations can shift, create more value for their patients and the communities that they serve, while continuing to, have the margin so they can stay open and stay in business. So thinking about these things should help us really have a seat at the table and be seen and thought of in a much better way. Organizations are just really hyper focused on health system growth. Super big cost pressures, and most strategies in health systems are aligned around how do we grow ourselves out of this, because we can't just continue to cut costs. So health system growth focused on M&A activities and improving clinical experiences. So extremely critical that HTM is seen as a strategic value to the organization and has a seat at the table. So, I'm an operator and I'm a chief operating officer. So I'm always like, so what do I do? Where do I start? How do I go? So I wanted to land on kind of what actions and what can you do? Where could you start? And I didn't want you to leave here thinking that, all this high level stuff requires, multi-year transformational programs and really a lot of work. I think there are some very key things that you could start with. And so here's a few things to kind of walk you through, maybe 3 areas that you could start with today. If you're thinking about how do I get a seat at the table, how do I be seen as more proactive, how do I be seen more strategic in your organization, think about the contracts. And if you don't have a real good handle and picture on your enterprise contracts, conduct a service contract inventory audit. Identify every active contract, its terms, its renewal date, what equipment is covered under that agreement, are those assets still in service, and really get into the details that we spoke to here a little earlier. Next, benchmark your top 10 highest cost contracts. So once you kind of have that view, how do I then take and say, where are my high cost contracts? If I'm going to do some benchmarking, how do I work into the details? How do I get the available peer data and identify those contracts with maybe the most variation? And maybe there's another way to look at it with renewal dates. What's coming up? And how do I dig into the details of those service models so that I can have a better optimized risk balanced strategy? And last, one here for you is just establishing that cross-functional contract review process. So if you don't have it today, partner up with supply chain, HTM department, clinical operations, and finance, and really get into setting, policies. Think about what you have today, but set policies on, contracts above a certain defined threshold. We can't do it all. So if it's above a threshold, what does the policy state that it should be renewed? It should be reviewed, before it's renewed. And, how do we go through that strategic evaluation process that we talked about today? One thought I wanted to leave you with is just, again, back to kind of what the market is and where the landscape's going. There's a ton of consolidation. So health system consolidation continues to accelerate. When you acquire new hospitals or merge with another system, HTM and all these clinical assets is one of the first areas where you can either, kind of realize synergies or maybe you can inherit hidden costs. Systems that have mature asset intelligence, standardized service models, and governed contract portfolios. These are the systems that typically can integrate faster with new facilities, and they also come from a position of strength, understanding kind of where their baseline is, how that compares to what the future might look like, and allowing them to have an HTM to have a real good conversation. And ultimately, it avoids maybe a potential trap of inheriting hundreds of redundant contracts that have variation, maybe above market, etc. So I think this is where HTM, another example of where HTM becomes a strategic enabler of enterprise growth and not just a maintenance department or a cost center. So in kind of summary and wrapping this all together, kind of 5 kind of takeaways that I think you could walk home with, or hopefully are walking home with, is a couple things here. First, build a unified data foundation. All right, that beyond just maintenance, it connects maintenance, financials, asset utilization, and ultimately contract data as a single kind of combined unit. Second, reduce service spend strategically by matching service models to the asset risk profiles in your organization. Third, create visibility into where your service dollars are going and why, making sure that you understand that and have a strategic action plan behind it if you need to make changes. Fourth, aligning HTM with the supply chain and really coming at it from a collaborative perspective, supply chain, finance, and even IT, as our systems become smarter and smarter around the shared outcomes and shared governance over the program. And fifth, treat this capability as a competitive advantage. This goes back to like being seen at the executive table and showing value to your organization. Because in this market, it's really, we're seeing really extreme cost pressures and as well as consolidation and razor thin margins, right? That drives all that back to razor thin margins at the end of the day, which executive teams in every single hospital today, that is probably top of mind of the margin pressures and how and what levers do they have to pull. So if you show up with a lot of these 5 kind of categories, you're going to be, showing the system that you're managing the technology investments and you're showing them how to best outperform and be seen as a strategic value partner. So with that, I just wanted to say thank you for the time today, and I hope that was helpful. If there are specific things to follow up with, I'm always happy to help. Renovo is always happy to help, so please feel free to reach out to us. I got a contact information here if you want to capture to get it, but we can talk about anything specific. And with that said, Linda, I will pull you back in, and I think we'll turn it over to Q&A.
Yes, thank you so much, Andy. We've got a few questions that have come in. The first one is, what's the first step if you don't feel like you have good visibility into your contracts and capital planning?
Yeah, that's a great question. And a lot of people don't have that and feel overwhelmed. I think there's a couple of first steps. One is really to understand in your organization where those contracts might potentially be if you don't have the visibility. And kind of back to a little bit of what I stated in one of those kind of first 30-day steps. But how do you centralize it and where those might be? Starting to engage with the leaders in those departments about why you think there might be some costs over there. And I think you can pull it back into this framework about how you're trying to think of a more strategic way and to create value for the organization to get them bought in. And then really trying to have a plan around how do I get that data centralized and governance around it. And so you're going to have to kind of take some guesses on where those costs might be. I think I mentioned system level, facility levels. Maybe there's procurement folks in facilities or even department levels like radiology or lab to go start having those dialogues and discussions.
Super. So how are others actually getting their arms around total service spend across all vendors?
There are several ways. There are some folks who are maybe members of a GPO. That's one avenue where the GPOs can help kind of understand what that total service spend is. There's also maybe some ballpark benchmarks that at least would get you directionally. What I always say is directionally correct. So like folks like ECRI or whatever on a kind of cost of service or estimated costs that give you a benchmark that could tell you for what you have, assuming you have to start with something, you don't have your arms around it all, but you're starting with something, might tell you how much effort and how much work needs to go into that. So I think those are a couple of ways to do it, and obviously partnering with your supply chain teams on where, and probably reviewing the policies for your organization as well of what they state, and maybe making some of those changes from a policy perspective that would drive folks to push more of that total contract and service spend into a centralized area for visibility.
So for systems that have moved away from OEM in certain areas, what gave them confidence to do that?
That's a great question. I think so probably driven by probably some of the financial benefits of it, but I think it's also confidence of starting. I think I talked about not with the highest, most complex systems, but starting with systems that might be your general kind of, bread and butter workhorses. Today, a 64 slice CT, or some of the assets that I go back to kind of mid-tier risk profiles of assets where, third parties, independent service organizations have great credibility and skills in that area, and really starting with a few, of those type of assets where capability exists. It builds a department's confidence in terms of response time and service and quality, and holding those vendors accountable. I think the other thing that drives credibility is, back to the SLAs and the KPIs and regular reporting of those KPIs so that people are delivering the same quality, the same service that the department needs. But starting in that kind of way is a nice way for folks to make that first step away.
Perfect. Another question that's just popped up. Do we see that organizations are actually benchmarking their contracts regularly, or is that still pretty rare?
I think it's extremely rare. Most of them will kind of pull out I think I talked about, pricing being good at on one of the pages, but most folks, what we see is kind of episodic. Probably, sometimes how patient care is treated, or if you're going to the ER, but a service contract pops up, it has a renewal, and not necessarily benchmarking back to the level of details that I talked about getting into, and understanding what services, what's all involved in that. But, give me a couple of prices that people are familiar with, and am I close enough? And that is quote unquote good enough. That's probably more of the reality versus really doing the apples to apples and really understanding what are the terms, what are the conditions, what are the entitlements. A lot of things we go through with our customers are entitlements, and sometimes the entitlements are great and create great value, and a lot of times those entitlements are in contracts or being spent on but not utilized. So really digging through some of that is the benchmarking, and most organizations just it's not a capability issue, it's a capacity. There's so much going on that it's really just a quick high level, is it close enough conversation is more of the norm, and good detailed benchmarking is rare, as you mentioned, Linda, or the question mentioned.
Great. Another question here is, now what role does a physical equipment inventory play in giving HTM, supply chain and finance the shared visibility they need?
Yeah, that's a great one, and I think a critical step. And it probably, depending on the time that you maybe last had a physical inventory and kind of a walkthrough. This is back to, I mentioned a lot of times in customers we work with as we maybe onboard them or start to work with them, 30 to 50% of their inventory is typically not accurate, meaning if you have 10,000 assets, you might have close to 10,000 assets, but you really don't understand half of those, 5,000 of them, and you're paying for some that you maybe have left your organization years ago. So a physical inventory is a great recommendation in terms of understanding where you're at. Inventory moves around month to month. New equipment is coming in, new equipment or old equipment is getting retired month over month, and depending on the timing of the year and the size of the organization, those numbers can be as many as 5,000-10,000 assets a month that are changing to a couple, and that makes it just a challenge. And so if it's been a while since your organization has really gone through a physical inventory, I would say highly recommended to really get your handle on what your current assets and inventory state is, and having the discipline to decommission and eliminate inventory that's no longer there so it doesn't keep popping back up.
Perfect. Another question here is, how can HTM teams better evaluate when it's more cost effective to repair equipment in-house versus maintaining vendor service?
It's a great question, and it kind of spawns from some of the earlier questions around really having a good understanding of your total costs and not leaving anything out. So I ran an in-house team for a long time, and so even getting into how much overtime is spent and the transportation costs and shipping costs and a lot of these things that sometimes people forget about from an in-house view. Really, how do you pull all of those? Do you have visibility to all of it? A lot of times organizational policies vary. We see this, and some organizations, costs are consumed locally. Some are at a system level, and a mix of everywhere in between. So really, from an in-house perspective, are you able to have, back to those previous questions, and really get a solid understanding with high confidence that you've captured a lot of your costs and all your costs? And then it makes it easier to compare kind of the apples to apples to maybe an outsourced program or a vendor model or whatever you're looking at.
Perfect. Well, so just before we wrap up, have you got any top tips?
Top tips. There's probably a lot of tips. I would say that the industry is amazing. Biomed technicians, imaging technicians, lab technicians, our technicians are always incredible. So the HTM space is super exciting. And I have, for those that have probably know me or close to me for probably a decade or two, I keep saying, how do we get the biomed out of the basement? So, today's discussion, hopefully another helpful step in that direction. But what HTM does for healthcare and for health systems is incredible. The safe patient care every single day. It's a mission that's absolutely worth getting out of bed for. It's what excites me. But we got to elevate ourselves. We got to get up, and the value we create every single day. We got to figure out how to talk about that a little bit differently to the executive teams and the executive level. So, and if you don't get it right the first time, like I never have, keep trying. Take another chance at it. Position something differently. Capture more information, but don't give up. So it's an incredible industry we have, and that would be my top tip, Linda.
Perfect. Well, thank you so much, Andy, for such an informative presentation. Thank you so much. Now, if you'd like more information about today's presentation and sponsor, please visit Renovo that's the number one.com. As promised, the answer to today's trivia question is Georgia. So congratulations to our winner, Ellen Frisch in Wisconsin. Now, just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit from the ACI, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. If you've missed any of our past webinars, including any by Renovo, please visit webinarwednesday.live to view our whole webinar archive. We'll be back next week with another webinar, so visit webinarwednesday.live for more details and, of course, complimentary registration. Thank you once again for your time today, and I hope you all enjoy the rest of your day.
Thank you, Linda.